Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Hello, good morning, good afternoon, good evening, everyone. Doesn't matter where you're joining us from, you're welcome. It's quite another exciting session of the Pataril, and we're happy to have you on board. We see that people are joining in. As you come in, if you see that a colleague is missing, reach out to them and tell them it's Pataril o'clock so that they join us and we can have conversations around the topic that is happening at the moment. I am Dr. Vanessa Fozaombi, PATA country representative for Cameroon, and I will be the chair for this PATA session. And we promise you this session is going to be one that will take a lot from when we do a PATA. And so we invite all of you to stay tuned. Today, we are going to be talking about clinic community collaboration in the management of pediatric HIV. And we have a powerful team that will be bringing that presentation to us. You're already connected, some ground rules. The great news is that there's interpretation on this session. So you could hit the interpretation button to get interpretation in French or in Portuguese, so that we have everybody included. We also invite you to use the chat box to introduce yourself, so we know who is connecting and where you're connecting from for this session. And you use the question and answer box to post questions that you may have for the experts on this call. Moving forward, like I said, this is PATA Real, and in as much as we say it is real, REAL is also an acronym that stands for reviewing cases, engaging with peers, accessing our experts, and learning lessons. So all the cases that we have prepared for you today is aimed towards just doing justice to what PATA Real actually means. We are going to be looking at cases from 2 countries. You will have the opportunity to engage and ask questions to your peers, and you also have access to wonderful experts that I'm going to be introducing as we move along. So for the powerful session of today, we have a panel of experts that we have put together, but also a panel of presenters from the front line who are here to do these presentations. Starting from our South Africa team, we have Rose Mokoto, who is here as she's affectionate about children, and she's fondly known as Mama Rose. She's a mother of 2. She is the founder and director of Lefika Laka, which is a community-based organization and is dedicated to improving the lives of vulnerable and disadvantaged communities. Thank you, Rose. You're welcome. Still from South Africa, we have Magdalene Gale. who is a registered nurse, and she currently champions pediatric activities and particularly works with children 0 to 19 in the facility where she works. So she's very involved in ART management when it comes to children. You're welcome, Magdalene. Moving over to our Nigerian team. We do have two powerful speakers as well. We have Dr. Jamila Osman, who is the pediatric HIV, who works at the pediatric HIV clinic of Aminu Kano Teaching Hospital in Kano State, Nigeria, and very passionate about children and anything HIV related to children. You're welcome, Dr. Jamila. We also have Dr. Farida Azira, who has extensive experience in advanced HIV disease and as well as community engagement and health service delivery. She's also a gender specialist, development professional, and researcher with expertise in gender advocacy. She works for SWACH. And SWACH is also a community-based organization in Kano State, and they are part of the consortium that is implementing the Impact for HIV project, strengthening advanced HIV disease awareness in Nigeria. You're welcome, Dr. Farida. And now moving over to our pool of experts, because remember that an aspect of PATA-Rail is for us to engage with our experts who are here. So as experts today, we have our very own Dr. Filiuka, who is PATA country representative for Tanzania and is a mental health specialist with experience in adolescents and youth mental health. Welcome, Dr. Filiuka. We also have Dr. Julie Sweetala, who is an infectious disease pediatrician working predominantly in TB care. Currently, she is a senior technical specialist in pediatric HIV and TB with the Arum Institute. But previously, she worked in TB facility in Cape Town. And so we have her here to respond to most of our questions that have to do with clinic community linkages. You're welcome, Dr. Sweetala. And lastly, and powerfully, we have the gentleman on the team. I'm sure people will be wondering, oh, why are they all women? Of course, we have men in our team who are here to support us. We have Dr. Achari, who is a pediatric infectious disease specialist in the Department of Pediatrics and Clinical Health at King Edward VII Hospital, affiliated to the Nelson R. Mandela School of Medicine, University of KwaZulu-Natal. He is actively involved with the management of children and HIV, both locally and nationally within South Africa. His research interests include antiretroviral drugs, therapeutics, viral resistance, optimum timing of initiation, and antiretroviral therapy in the developing world. So we have all these great panelists who are here to make sure that we have a beautiful show. And if you're just joining us, you're welcome. Again, today we are talking clinic community collaboration in the fight against pediatric HIV. And right away, I'm going to usher in the South African team, who is going to take us through the first presentation. Thank you. Rose, you have the floor. Thank you.
Good afternoon, Dr. Vanessa. Magdalene will start.
Are you ready?
Magdalene, go ahead. It gets real. Go ahead. Thank you.
Good day, colleagues. I am Sister Magdalene Ngale, and I'm all the way from South Africa, and I'll be doing the clinical presentation of this case. Please bear with me a little bit.
Hey, Magdalene, can you see the case projected on your screen?
Oh, I was already opening up my own presentation, but it's fine. I'll go back to your Mine is blurry. I cannot see. It's way too blurry.
Let's just give it a minute. Magdalena, are we good?
No, not yet. It's still blurry.
Can you follow from your own site what you have?
I think it'll be better if I follow from my side. Because Luna.
You understand that these are frontline healthcare providers. Magdalene is still on the field, but she's happy to do this presentation for us. So hopefully her technology is going to let her do it for us. Are we good?
No, not yet, not yet. Let's see. Yeah, I'm good to go.
All right, thank you. You have the floor. And thanks to everyone for being patient. Now we listen to Magdalene. Thank you.
Okay, colleagues, like I said, I am Sister Ngale, all the way from South Africa, and I'll be doing the clinical presentation and diagnosis in this case. So this is a case of a 12-year-old male patient who was diagnosed with HIV in infancy, and it was likely transmitted through breastfeeding because now this child was born HIV negative, but somewhere along the lines, and then he tested HIV positive. The initial diagnosis and treatment was done at another hospital, followed by a period of disengagement from care. So this child first presented at the clinic that I'm working in February 2024, presenting with symptoms suggestive of TB and meningitis. Since then, the initial HIV status was not known. We had to now refer this child for retesting, and then he was tested, and indeed he was HIV positive. It was now a confirmed case. So due to the TB and meningitis symptoms, he was tested for TB. We took specimens for TB, and then we also took specimens for baseline bloods, and then we now had to refer this child to a higher level of care, which was a hospital in this case, where then they had to now rule out the meningitis and also continue to work up on the TB symptoms. So now the initial, excuse me, the initial specimen that was taken for a basic TB NAT test, it tested negative. However, this patient still continued presenting with TB symptoms. So at the hospital, they further ran a TB culture test, and the patient underwent X-ray, which then confirmed that this patient had pulmonary tuberculosis. He was then started on treatment on the 6th of March at the hospital, and then he was also started on cotrimoxazole prophylaxis on the 6th of March 2024, which he then completed and was declared TB-free in September 2024. So now, after initiation at the hospital, when the Meningitis was then ruled out. He tested meningitis negative with a confirmed pulmonary TB positive. He was stabilized and then later on referred back to the facility. And then we had to now reinitiate this patient back on ART on the 3rd of April in 2024. And then at that time he was weighing 28 kgs. And then we now gave him now a return date to come for a review in May. He did come and then followed up in June, where we could see a significant weight gain, which was an indication of much improvement and doing well on treatment. So now on the 3rd of April in 2024, since he was weighing 24 kgs, we then put him on the ALD1 regimen, the abacavir, lamivudine, and dolutegravir regimen, and also continuing on TB treatment. But then coming to June, he was then weighing 32 kgs, which then warranted him to be switched from the ALD regimen to the TLD regimen. And then we had to now further assess how he was responding to the treatment. So now this child was due for a viral load checkup in July 2024. However, it was missed by a clinician who was managing this child. The mother did come to collect this child's treatment on the 6th of August and on the 3rd of September 2024. Now, this child's final date in TB treatment was on the 26th of September 2024. And unfortunately, the mother could not come with the child. She did indicate that the child was now being reluctant and refusing to come to the clinic. Then after being discharged from TB clinic, he was declared TB-free. He was then expected to come back to the clinic to continue with the ART in January 2025, but he unfortunately did not show up. There were several efforts to re-engage him to care with a little success. Then the community partner from Lefika Laga then came into the picture. And then she went and traced the child, and successfully this time she did come with the child. All right, so going on to the additional investigations and treatment history. This child was now brought back by Lefika Laga team on the 18th of June 2025. He was then presenting with severe toothache and swelling on his right mandibular area. On examination, he was in severe pain, and then we could detect tenderness on the right submandibular area, and he was unfortunately unable to open his mouth fully. However, as we continued to assess this child, we could see that the throat also seemed swollen. So we had to now give analgesia in order to relieve pain at that moment. So now we went further to screen this child for possible TB infection. We discussed this child now with the doctor who was on site, and then she now advised that we should refer the child to the hospital, as this was now an emergency case. We went on to take on baseline bloods for initiation of ART, and then we further went on to still screen this child for opportunistic infections, including TB, as we were unsure if this might have been a case of reinfection of tuberculosis or not. And then after that, we referred this child to the hospital for further investigations and treatment. And then at the hospital, he underwent tooth extraction the following day after admission, and then pain and swelling was then addressed at the hospital. So this child was hospitalized for about 3 weeks, and during this period, he was offered both medical and psychosocial support. Then I'll go on to do the viral load history of this child. So on the 20th of April in 2024, this child was weighing 28 kgs with a CD4 count of 8 cells and a viral load of 106,333 copies. And then now that the CD4 count was less than 100, the laboratory then ran an automatic test on crack antigen, and he was tested crack antigen negative. And then after April, remember we had missed now the viral load in July. The only time we were able to collect his specimens for viral load was in November. So in November, he was weighing 30. Yeah, he had now lost 2 more kgs because now we are dealing with a case of a patient or a child who is poorly adhering to treatments and also not so well adhering to return dates that are provided to him. So now in November, yes, November 2024, he weighed 30 kgs. That's why we now switched him from the ALD regimen to the TLD regimen. And then now his CD4 count was 99 cells. And again, his crack antigen came back negative with a viral load of now 13,377. And then that's when he now became a lost to follow up case once again. And then on the 18th of June in 2025, this is when he was traced back to care successfully. We took baseline bloods that did not include viral load workout, but his CD4 count was 19 kgs. And then his crack antigen still came back negative. So further care was then done from the hospital set up, and then they ran a viral load test, which was now 51,353 copies with a CD4 count of 11 cells, and once more a crack antigen test of negative. So we do not have any more information, any more medical information, as this client is now a hospital case. So I think this marks the end of my presentation. I don't know if I should go ahead and ask the question or we'll do the question after my Rose is done with her presentation. But for now, I'll hand over to my Rose.
Thank you.
All right, thank you.
Good afternoon. Thank you so much, Dr. Vanessa. So the child came to our attention in March of 2025 as he was already confirmed lost to follow up. And in case of what we had seen, as Sister Ngale had indicated, he was also not suppressing. We went out as a team and found him living in a one-room shack, very poor condition. The mother and father are separated, and the child was actually going through a lot of neglect. If you can see the photos of how he was wearing, and the fact that the mother left the child in the shack with a toothache and very sick was also telling of the story. They don't have a proper home. They're moving from one shack to the other informal settlement, and hence the history that he was not adhering, and it was difficult to take them in. We immediately took the child to the hospital on the 18th of June, to the clinic, and where he received immediate medical attention. But over and above that, we also dealt with the social services, because this is clearly a case of social welfare, where we had to involve the Department of Social Development. Next slide, please. And what happened is that we then, after Sister Ngale had seen the child as she presented on the 18th, the child was then referred to hospital. We accompanied the child through to the hospital. And at that point, the child was then referred to another hospital where the surgical team was supposed to see the child to relieve the pain or extraction. In this, after tooth extraction, the child was admitted in a medical ward where for about 3 weeks, where we continued to go to the hospital, engage with doctors so that we give them the correct history, but we also highlight the plight of this young boy. We provided food, we provided some clothing, as well as toys that would stimulate him, because in terms of education, he was already in grade 4 when he was supposed to be in grade 7. And during this period, we also requested the hospital to make sure that he gets the psychosocial support, where they involve the psychologists as well as the social workers. And unfortunately, during this engagement, there was an issue of suitability assessment that was done to place the child with the father, because from the previous history, the child was adhering better when he was with the father. But now the father was living about 150 kilometers away. But unfortunately, at the end, the child could not be placed with the father. And as we speak, the child was back with the mother. And we're trying to sort the issue of alternative placement. Next slide. And what we also did as part of advocacy and support and making sure that this child receives what he deserves, we went to the Advanced Clinical Care meeting on the 30th of July, where the Department of Health and other stakeholders are sitting to present the case. And out of this meeting, there was certain decisions that were made that we needed to get social workers down to the ground, and the issue of transport as a barrier was addressed. We also heard that the Department of Health will collaborate with the Department of Social Development to address these issues. There was supposed to be an urgent meeting between the hospital and the PAC facility. The reason for this is that we have seen in the case that the child is now back to the same conditions, but at the same time, there's a challenge of down referral or collaboration between clinic and PAC facilities. We're also looking at an adopted child strategy, which is implemented by the Department of Health, and seeing how best we can make sure that this strategy works very well. And lastly, to make sure that we display the children's register and the children's rights in the facilities. And some of the challenges from the cases that we are seeing that there's so much relationship between treatment adherence, impact of neglect, and then it's just overall comprehensive of care, that you can't just address the medical aspect without dealing with other determinants that influence the health outcomes. And the lessons that reflect is that we need an multidisciplinary approach in dealing with cases. We also need robust follow-up systems, because you can see that it was about 6 months that this child could not be found. And clearly we need to review the systems and also address the root causes of neglect as well as abuse. Thank you so much. Oh, we just had, we have a clinical question as well as the psychosocial support question. Dr. Vanessa, you can guide me whether should I go through this question?
Please go ahead and just pose the 2 questions. Thank you.
Yes, so when we looked at when Sister Ngale presented, you saw that the child was staged WHO clinical staging 3. And this was also in line with the guidelines in South Africa on adult primary care, where that they are required to stage the child at every visit, and with the view that the child will almost move back to stage 1. So we just wanted to clarify on the issue of regression. But lastly, we wanted to check with other countries, how are they dealing with the issues of determinants, especially social determinants that hamper the issue of health outcomes. Thanks.
All right, thank you very much to Magdalene and Rose for that presentation. We see clearly that communities need to work closely with the facility, and this was a case of the facility referring a case to the community. If you're just joining us, we are talking clinic community collaboration in the management of pediatric HIV. Right now, I'm going to hand the floor to our experts who are going to respond to the cases, but I also want to call on the team that presented that there are some questions for them on the Q&A box, so they could also respond. So right now we're going to have Dr. Achari, we're going to have Dr. Fuyuka, and Dr. Switala respond to the questions that have been posed. Thank you.
Great. I think thanks, Mary. I can start off, and maybe just to compliment the team again. I think these complex cases with, quite complex psychosocial and family dynamics, does require a multidisciplinary approach and not just a biomedical approach. And I think, the team has really expounded on that and really tried to get as many people involved in the care of the child, to get the best outcome. I think just a few points from my side before I hand it over to the other team members. I think once, again, I think this child represents what we determine as advanced HIV disease with very low CD4 count and WHO stage 3 or 4, depending on whether it's just primary TB or disseminated TB. Again, I think as the group has noted, you do need to look for other opportunistic infections. So again, they looked for PJP, so pneumocystis, and provide prophylaxis. TB, looking for it and actively, ruling it out. And again, I think this case highlights the difficulty in terms of making the diagnosis of TB in a patient with advanced HIV disease. So, other tests that you can use includes the urinary lamb test. And again, I think it's very useful in children or adults with advanced HIV disease with low CD4 counts, where it has a relatively high sensitivity. The other one is stool GeneXpert, especially if you have abdominal TB, as you seem to have suggested in this patient. Sometimes we'll get, even in an older patient, you may get a stool positive as opposed to a sputum positive. The other thing I just wanted to speak about is really around in terms of, when you start a patient on TB and HIV test, especially when you're using the rifampicin-based regimens for TB treatment, you do need to alter your HIV management. So in this case, because the patient was on a dolutegravir-based regimen, you do need to give them twice daily dolutegravir as opposed to once daily dolutegravir to overcome the effects of the rifampicin on the dolutegravir. If you're on a PI, you may need to modify that PI-based measurement, the treatment. And then the other thing I would just make is really around disclosure, and I wasn't sure whether this child has been fully disclosed to and how much of they've been involved in that diagnosis, the treatment plan. I think it's important, especially in an adolescent, to get them involved in their treatment plan and get them engaged in it, because they have to take on some responsibility. And I think ultimately is trying to find who is that individual who can look after this, help and support this child. And I think it seems like the father seems like the most logical choice. I think I'll lastly end off with just trying to answer the question around, the repeat recurrent testing, evaluation of the WHO staging. So the WHO clinical staging was really not designed for monitoring of HIV response. It was really designed for determining, when to start antiretroviral treatment and looking at the probability of mortality for it. In the case of, where we do it, serially, essentially what you're looking for is any new features of a new WHO staging care. So I think in this patient, I think if it's primary TB, it will be stage 3. If it was disseminated TB, it would be stage 4. I think once you have that, and then you reassess the patient the next visit, looking to see is there any new features of either stage 3 or stage 4 disease. And again, I think it does give you some indication that there's been poor response to treatment, including weight. So I'll hand over to the rest of the panelists and maybe to add on. Thanks.
Thank you very much. And I also really want to commend to the team for the support of this of the child, and up to currently the way they were really collaborating with the community and providing support, understanding these determinants, and start to even providing psychosocial support to the mother. So holistically, I will look like this is the very, we say the early adolescent child, And I think Anchari was also talking about the disclosure, whether this patient was disclosed and how the disclosure counseling and all that went through, because it's a very important for a 12-year-old to understand their illness. They have so many questions. And I can see there's one moment that even the child was refusing to come to the hospital. And also because the child, they don't have any say, mostly we often start counseling to the parents, especially the ones who are really the caregivers, the ones that were supporting the children at the community. So with this, as I see that you start counseling and providing mental health support to the mother, that is a very important step, so that herself, we're still unsure what was the source of the neglect. Could be also the mother was also struggling mentally, and that could be the one or the thing that if was also assessed and screened for mental health conditions, and for him to get for her to get the treatment. Other thing is the yes, we understand of the resource constraint, but we have these community health workers and also the peer supporters, or even the children, the adolescents at that age, who are also maybe very they are good adhered to the medication. They could even support or put into the group, in the support groups, would have been beneficial for this young child, so that he learns that he's not alone, and there's other people who are also have similar problems, and they can even struggling in a way that he could even get some answers to the questions that he has. And additionally, thinking around what other countries, I think South Africa is one of the countries that have very good system in clinic community collaboration, but also thinking around the facility needs to understand what is around, what other organizations, CSOs, other things that is around that can support them and link them to those organization. So whenever the case like this is happening, you know where to contact and get support from. So I know the time it's not on our side, but for this is I really commend for what is happening right now, but really put this child into support group, like peer support group, in the clinic, so that he also learn that he's not alone, and there are other children who are also thriving, and support one another to be more stable and resilient. Thank you.
Thank you, Dr. Julie.
So much, and for such a difficult case, and this child seems to have tried to die so many times, and the clinical team has pulled him out from that many times. So well done to everybody. Just one thing I want to highlight that I think was done very well, because it often isn't done well, is this is a child who was diagnosed with TB meningitis, and the guidelines for South Africa are that children with TB meningitis need 9 months of treatment and not 6 months if they have HIV. So well done to the team for sticking to that. There's quite a bit of clinical information I would have liked to understand the case a bit better. So the first thing is, do we have any idea what happened for those first 12 years of life? Was there a reason that that child disappeared from care? Was the mom even aware of his HIV status? And a little bit more history around there would have potentially been helpful to see why we're having problems at the moment. And also if the mother was taking her own treatment at that time. So the fact that she's remained well and is even alive 12 years down the line makes me wonder if she was on her own treatment, and if she was, were there really child-friendly services to keep that child in treatment with the mother? So I feel very strongly that if we need to make this easy to stay on your treatment. And if we are expecting mothers and children to go to separate clinics, be seen by separate doctors, have different clinic appointments, then the reality is somebody's going to fall off the bus, and it's often the child. So I'm not sure if that happened in this case, but I would have liked a bit of history there. And I think the team also did very well to keep screening for CRAG and for TB again and again and again because of that low CD4 count. So I think that was really nicely done. What's also not completely clear to me is if he stayed on his ARVs while he was on his TBM treatment. Because if he did and he was declared TB-free, something was working during that period. And if we look at the viral load pattern, he was never fully suppressed, but there does seem to be a period where he was at least taking some of his ART. So sometimes I think the right trick is really going back down to the detail. Is this child getting the right amount of treatment for his weight? Is the dosing appropriate for his weight as it goes up? As Prof. Archery mentioned, have we boosted the ARVs while he's on TBM treatment? And I think also remembering that TBM treatment makes these kids vomit terribly. So, you know, we don't know if maybe the mom was really struggling to get this child to take his treatment because he was vomiting every day. And are there little hacks that we could try to make it a little bit easier for this mom to actually get the medications in? The other thing was we hear that the child refused to come to the clinic. I would have liked to have known what this child's mental and neurological state is. This might be a child who's been walking around with an unsuppressed viral load for many years. He's also had TB meningitis. Does he have normal, you know, can he even walk? I mean, is this a child who's got cerebral palsy? Is this a child who is able to participate in his own care at all? So I think all of those things matter. But I actually think the most important person in this whole story is the mom. We know very little about her. And I think that she sounds like the bad guy in this story. But I think we don't know how well she is. She might be incredibly unwell herself. She might be struggling also because of the psychosocial concerns, but she might have medical concerns that are making her unable to look after this child. There are things that we can give a mom like this in South Africa. We could give a mom like, make sure that she's getting a child support grant. And I think if I could do one thing in this case, it would be let's help mom. I also don't completely agree with Prof. Archery that the dad is the solution here. Where's dad? Is dad giving the mother money to support this child? Has dad come to visit and noticed that his child is really unwell? So perhaps that is the right answer. But I think before we walk away from mom, we need to uplift mom and really, really try to get small goals, get her to meet those small goals. And most moms want to be a good mom to their kids. And sometimes they just need a lift one way or the other. Thank you for a very nice case. I hope that helps.
Wow. Thank you very much to all our experts. Let's help mom. Thank you very much. Please, the team, there are some questions. There are lots of comments that have come that I'm sure is going to help us to really globally manage the case. But I just want to implore us, the questions that have come through, please let's provide responses in the Q&A, just so that everybody can come up to speed with the gaps they have in their heads concerning this case. But thank you very much. And right away, we are going to make a switch and we are going to Nigeria. Yeah, for Nigeria, we are going to see the reverse of what happened in South Africa, where the facility was referring a case to the community. Now in Nigeria, we are going to see a case of the community referring a case to the facility. Remember, we are doing clinic-community collaboration for to completely manage pediatric HIV. So if you're just joining us, you're in the right place. Stay back, and now we listen to the Nigeria team. Thank you.
Hello, good afternoon, everyone. Afternoon, evening, morning, depending on where you are listening from. And my name is Dr. Farida Azira Abdul Malik, and I'll be presenting a case of a 10-month-old baby that was diagnosed with HIV. So I would throw it back to, okay, in January, early this year, 2025, a 10-month-old baby was diagnosed with HIV, and her mother was first identified HIV positive 2 months prior to that. So during a SWAT community HCS outreach and initially diagnosed at Ungwa Oku PHC, is a primary health care center in Kano State, Nigeria, When the baby was 7 months old, she was later referred to AKTH, that is Aminu Kano Teaching Hospital here in Kano, for reconfirmation again and PCR test, where the baby was actually diagnosed positive. So here is the real story when we actually had a counseling session with the mother. The mother disclosed to us, Swatch organization, that when she disclosed her status to her husband initially, she was met with stigma and rejection because at that point, he did not want to have anything to do with her. And then he refused to get tested because then she tried to, talk to him into him also getting tested, but he just didn't want to buy the idea. He didn't want to listen to her at all. And then she has a co-wife. So she tried to see how she can actually convince the co-wife to get tested, but then the husband prevented the co-wife from actually being tested and also forced her to get tested repeatedly at different facilities, of which confirmed her positive status still yet. So he only recently revealed his own positive status later on, but he still divorced her on the grounds of her being HIV positive, diagnosed with HIV. I think he divorced her the fact that she broke the news first, and then abandoning the baby they had together. So she mentioned that the husband denied her access to facility. He denied her access to facility when she was pregnant. So she gave birth in a traditional way at home, and then which led her giving birth in the community, and she did not attend any antenatal session at all because he forbade her to have access to healthcare services, which actually increased the risks of, the vertical transmission, the HIV transmission to the baby. So for the social and economic status, the mother is divorced and also survives on petty trading. She sells, she disclosed to me that she sells dried local groceries at home so that she can make ends meet. Okay, so this generates very little income for her. She faces financial hardship and also food insecurity, struggling to provide nutritious meal for herself and the baby while remaining on treatment, which is very, very key and important. For the environment, the client's environment is marked by stigma, obviously from her husband and her co-wives, and also lack of spousal and extended family support and severe economic hardship. So these factors limit her access to healthcare and also affect treatment adherence and undermine her ability to adequately care for her baby. So now we would move to what happened next. So after being referred to AKTH, which is Aminu Kano Teaching Hospital here in Kano, the baby's PCR tested confirmed she was HIV positive, and at 10 months, she presented with cough and breathing difficulties and was later confirmed to be TB positive through TB LAM testing. She commenced anti-TB treatment and was subsequently initiated on ARV with diagnosed adjustment due to the TB treatment. So through our community intervention, Swatch was able to provide the mother and the baby with the following interventions: early HIV testing and prompt referral to the facility care. And Swatch also provided psychosocial counseling to cope with stigma and rejection, and also adherence and nutrition support for both the baby and the mother through an adolescent support group called Godia Support Group. And then again, Swatch was able to link the baby to Operation 000, which is a GGHN platform where the baby was given Tom Brown that would help to boost the nutritional system. It's also an adolescent support group also, which actually supports adolescents with nutritional support. So Swatch was also able to support her with transport allowance to make sure that she attends the support group, to help her with self-stigma and also, boost her self-esteem. And then there's continuous follow-up and community-based stigma reduction counseling. So we do follow up on her from time to time. So on the next slide, I will talk about ANIDE Consortium strength. So as you all know, Swatch is a partner of or is a consortium member of ANIDE. And together we carry out a lot of activities, which is our strength in 4 different states in Nigeria. The first one is we carry out identification, Counseling, testing, we work with community health workers and traditional birth attendants that are now renowned trained birth attendants. We engage with them to carry out HTS activities in the community. And we do carry out family-centered outreach to ensure early case detection in strategic areas. And then we do prevention. We do early diagnosis, community education, and ANC home delivery linkages to help prevent mother-to-child transmission, because we do realize that there is a number of women that still give birth at home and don't have access to health facilities for different reasons. And again, we do retention to care. We try to keep up with the strong referral system, psychosocial support, and advocacy for nutrition and social protection to keep mothers and children in sustained care. And we do collaborate with organizations that provide nutrition support to make sure that it complements our clients at the same time. So for community ownership, we try to engage with traditional and religious leaders in community-led monitoring. This strengthens accountability and reduces stigma, community stigma or family stigma around, and also promotes sustained community participation. So next, I think the clinician would take this part, and then I'll come back for the challenges. Or Dr. V, should I go on with the challenges before the clinician?
No, the clinician should go ahead. Thank you.
Oh, okay. Thank you. Dr. Jamila, over to you.
Good afternoon, everyone. Good day, everyone. So I'll be taking the clinical presentation of this patient. As at the time he was referred to AKTH, Aminu Kano Teaching Hospital, she was 10 months old, newly diagnosed, and she presented with cough, difficulty in breathing. On examination, she had widespread crepitations, though a chest x-ray was normal, but a TB lamp confirmed her TB status. So she was started on anti-TB and commenced on ARVs at least about 2 weeks later. She was actually commenced on the 26th of August, 2025 on ARVs. So we gave her the ALD, abacavir lamivudine DTG, and we also doubled the dose of her DTG since she was on anti-COX. The next slides talk about, shows her some of her investigations. Urea, electrolyte, and creatinine, and some of her CBC count results. After she was placed on anti-TB and ARVs, the mother had adherence counseling on the child's medication because she said that the child was not really tolerating the medication. She usually throws up after taking the dose of TB and ARVs. She was properly counseled on how to go about it, and then she said the child was now tolerating it better. The mother was also counseled on proper feeding of this child because her weight was not in accordance to her age. So feeding on high protein pap and preparation of the high protein pap was taught to the mother, which she would give the child. So because she is recently diagnosed, we have not done her viral load yet. The result on the viral load is actually supposed to be her CD4 count. I think it was a typing error. So her CD4 count was greater than 200 cells. So according to the national guidelines, once she's 6 months, to our national guidelines, once she's 6 months on ARVs, we will do her first viral load. But so far, the girl is tolerating her ARVs and anti-TB. Thank you.
All right, I'll be taking the challenges and lessons learned from this case. So for the challenges, stigma, lack of spousal support, and eventually divorce, abandonment, leaving mother and child vulnerable is one of the challenge. Second one is financial hardship and food insecurity affecting child nutrition and maternal adherence. The third one is strain of care for the baby with HIV who has progressed and AHD, who has progressed to AHD without adequate support. So for the lessons learned, well, we have learned that women who do not attend antenatal care or delivery in the community are at high risk of having HIV exposed or HIV infected infants. And also collaboration with traditional birth attendants, now trained birth attendants and community health workers can help identify women who miss antenatal services or deliver at home, ensuring early testing and linkage to the facility. And then lastly, gaps in social protection programs affecting access to nutrition and support services for indigent women, furthering limiting adherence and care-seeking behavior. So I'll move to the question for the S part. I have about just 3 questions. The first one is, in this case or scenario, the woman was first tested in the community and only later was her child tested at a facility. So how can referral and linkage system be strengthened to ensure that children identified through community testing are promptly placed on treatment without delay? And secondly, what strategies can be implemented to systematically identify and support women who do not attend antenatal or who deliver at home to reduce the risk of vertical transmission? And the last one is, given the role of poverty and food insecurity in adherence, how can social protection and nutrition programs be better leveraged to support indigent women and children living with HIV? Thank you everyone for listening.
Thank you very much, Dr. Farida and Dr. Jamila from Nigeria, for bringing this across. If you're just joining us, we are talking clinical community collaboration to put an end to pediatric HIV. At this point, I'll be calling on our experts. And again, I want to plead that we start with Dr. Achari, after which we'll have Dr. Julie, and then we'll have Dr. Philippe wrap it up for us beautifully. Thank you.
Yeah, thank you very much. And again, thank you. Great work from the team, really around supporting the family and providing support to this mother who's quite a difficult situation. So I think the main thing, when we're dealing with these cases where there's a breakdown in the community system, is really to see how do we find linkages within the community, and may not be, and from some of the research that we've done around family-centered models of care, what we find is that women often find it's not just the individual family that they're looking for. They're looking at there's other members within the community, whether it's a neighbor or a church member or someone or a elder family member who provides that support for that. So I think in our context, that family-centered care can be not just family, but everyone around them that can assist this mother. And again, I think there's been quite a few comments in the chat as well around the involvement of men and fatherhood around supporting this process. And again, I think from the previous case, it's not just there's one or the other. We do need the both, and sometimes you need to focus on one area and then allow the space for the other individual to overcome whatever difficulty they're having, and usually we find they have time to come back from it. I think in terms of the antenatal care and ensuring continuity of care is really to make sure that there's ongoing support and linking both the mother's care with that of the child as well. So again, linking maternal and infant care is extremely important, and it allows for more synergies around providing that care and that holistic care to both the mother and the child. So I'll hand over to the other panel members.
Thank you, Dr. Julie.
Thank you so much, Sean. This is another very tricky case. I think just to answer the first question about the 7-month-old, I think what makes it difficult in this age group is that it's a bit easier to do testing on the mother, because that would be a point of care test. And usually on the baby at this stage, we would recommend a PCR test, because if we have a positive rapid test, we're not sure if it's just antibodies from the mom or the baby's own HIV. So sometimes, even though we know we can only really make the diagnosis on this baby with a PCR, just doing the rapid on the baby and getting a positive at least buys them into the system. So we still need to send a PCR, but at least we know where we're going with this baby, that he might have HIV and it might just be antibodies from the mom. That if it was negative, then we wouldn't be too worried about that. So I think that would be one thing that might be a bit of a delay here. The other thing is people generally struggle to take blood on these small babies. And I've seen at a lot of clinics, people are so scared of the actual act of taking blood from these babies, and that's the only reason that they refer the child out to a hospital. And then there are problems with, I mean, in this case, you've got presumably the sort of financial purse holder in the family who might not be so keen on paying for this child to be transported to a hospital. So that could be a concern there. Another strategy I've sometimes used with moms who find out that they're HIV positive and are very scared to disclose to their partners is to actually recommend that they come as a family to test from scratch. So then it doesn't become a situation where the mother has to go and disclose to her husband. She could say to her husband and the co-wives, I think we should all go and test. And it doesn't really matter who tested positive first, then they test positive as a family. And in this kind of scenario where it seems like quite a patriarchal setup, if we appeal to the father in this family to say, hi, men take responsibility for their families and their children. Why don't you bring all of your wives and make sure that we're running that sort of well? So I think in a scenario like this, it might be helpful to get the dad in and we test everybody together, even if we secretly know that one or two of the members in the family are already positive. I think that one of the questions about food insecurity, something we find quite often in South Africa is that there's not that much understanding on food literacy. So what I mean by that is we know that financially feeding a child can be really, really difficult. But in South Africa, there's such a preference for meat, for example. So people will spend all of the money that they have giving their children quite poor quality meat instead of thinking of alternative protein sources like beans or eggs or things that are a little bit easier. So I think just giving very basic advice on how to utilize the crops that you can grow yourself. When you are standing in a market trying to choose which foods to buy for your child, trying very hard to push hard for good nutritious food and just give a little bit of nutritional information on how to make a little bit of money go a long way. I hope that's enough. I'm sure I've left enough for Dr. Jamila as well.
Thank you, Dr.
Thank you very much, and thank you for the presentation. Yes, this case it was very difficult, and I really compliment with the SWACH intervention in the community that support the mother for all the social challenges that the mother has. But one question I want to ask, because if you tested the mother at the 7 months, when the child was 7 months, was the mother initiated medication at the community level, or she was sent to the facility? Because that is could have even proposed that the mother could come with the child so that he can get the PCR test at that 7 months, so that we cannot delay and see how the child is doing. I also really second the involving the family as one to come for the test, so that we test everyone within the family. That's also another thing that we could do, so that we know even within the family member, even though we know the mother is already HIV positive, but we can set a session that we can do a counseling and test for that. For another thing is about the social protection and food insecurity. from what I know in our communities in Africa, we have different kind of food we are farming, and so from that, I think the community education, because we already have community intervention, you can provide those nutrition education on using the same kind of food that they are producing in that community, and educate them which ones are the proteins, which ones are the good for different, which ones are healthy, so that they might not think only the food that they like meat, or which are very expensive, or something which is very expensive compared to the one that they have within the community there. So with that, with social protection, in my country, we have women's group. We call them Vikoba, but these women's groups, sometimes they provide support to one another. So if they may have those women's groups that they can provide support to one another, they can educate themselves, they can share their challenges, and then they can get something that they can work on. So all that can be also applied to this case, and improve the health of the mother and the child as well. So thank you very much. I know it's the time. I can see Vanessa is just looking at me there. Thank you so much. Appreciate it.
Wow. Thank you very much. I think it's clear today that we can end pediatric AIDS by 2030, but communities need to work in collaboration with facilities, and facilities need to work in collaboration with communities. The two cases have shown us today that either linkage is possible. The facility can refer to the community, and the community can refer to the facility. I'm happy that all the actors in this case did not stay on their high horse and say, no, the other person has to come and meet me. But they were proactive enough to take steps towards making sure that the children are at the center of care, and they are providing the best outcome for these children. We want to say a very big thank you to all our presenters today. We want to thank the team from South Africa, Magdalene, Mama Rose. We want to thank the team from Nigeria, Dr. Davila, Dr. Farida. We also want to thank our experts, Dr. Achari, Dr. Julie, and Dr. Filuka. And we want to thank our technical team, Angelita, who is always behind the scenes to make sure that we have an excellent reel. And we thank our interpreters as well, and everybody who contributed in one way or the other to making sure that this session was the success that it is today. And just to say that we are going to be having another Pata session on the 25th of November, 2025. So watch out on your screen. We'll be reaching out to you to inform you about that webinar. And please send in your cases. You never know. Next time it could just be you speaking to other colleagues, engaging with peers, and making them know that it's possible to get solutions when we do the simple things. So thank you very much for being there today with us and taking part in this Pata session, and see you in November. Bye-bye.